Chapter 10, Respirations and Artificial Ventilation. This is again another very important chapter to learn and to understand. Topics we are going to discuss are physiology and pathophysiology, respiration, positive pressure ventilation, oxygen therapy, special considerations, and assisting with advanced airway devices. In this section, we're going to talk about physiology and pathophysiology. Physiology and pathophysiology, the mechanics of breathing. Ventilation is the process of moving air into, which is inhalation, and out of, which is exhalation, of the chest. Inhalation is an active process. Chest muscles expand and the diaphragm contracts. The size of the chest then increases, and negative pressure pulls air into the lungs. Exhalation is a passive process. That's when the chest muscles and the diaphragm relax. The size of the chest then decreases, and positive pressure pushes air out of the lungs. Tidal volume is the amount of air moved in one breath. Minute volume is the amount of air moved in and out of the lungs per minute. Ventilation is designed to move air into and from the alveoli for gas exchange. Not all of the air breathed reaches the alveoli. Some air occupies dead space. The alveolar ventilation refers to the amount of air that actually reaches the alveoli. It can be altered by changes in the rate or the volume, and it depends heavily on tidal volume, but is also affected by the very fast or very slow rates. Physiology of respiration. The alveoli form the ends of the bronchial tubes, bunches of sacs which are inflated and ventilated as air moves in and out. Each alveolus is a bubble-like structure. The pulmonary capillaries brings blood close to the sacs. Thin alveoli and capillary walls allow for the gas exchange. Oxygen in the alveoli moves into the blood. Carbon dioxide in the blood moves into the alveoli. Diffusion is the movement of gases from an area of high concentration to an area of low concentration. Pulmonary respirations is a diffusion of oxygen and carbon dioxide between the alveoli and the circulating blood. Cellular respiration is diffusion of oxygen and carbon dioxide between the cells and the circulating blood. In order for pulmonary and cellular respiration to occur, the respiratory and circular system must work in conjunction. This is sometimes called the cardiopulmonary system. It may also be called a ventilation perfusion match. When either the respiratory or the circular system fails, the process of respiration is defeated. Cardiopulmonary pathophysiology. Mechanical failures of the cardiopulmonary system limit the ability of the chest to create pressure changes. Stab wounds allow air into the cavity and make it impossible to create negative pressure. Loss of nervous control makes it impossible to make changes to the respiratory muscles. Painful chest wall injuries limit the chest wall movement. Airway problems like bronchoconstriction limit the airflow. Interrupted gas exchange impairs the ability to diffuse oxygen and carbon dioxide. Low oxygen levels in outside air limit the amount of oxygen that can be inhaled. Diffusion problems caused by the alveoli that do not work properly limit the ability to exchange gases. Circulation issues prevent blood from carrying enough oxygen to the cells of the body. Significant blood loss reduces the amount of blood circulated to the alveoli. Insufficient hemoglobin or hemoglobin that is not working properly limits the transport of oxygen. In this section, we're going to talk about respirations. Adequate and inadequate breathing. Brain and body cells need a steady supply of oxygen to maintain normal function. Hypoxia is a low level of oxygen function. Hypercapnia is a high level of carbon dioxide. assesses the cardiopulmonary system by evaluating how well it is oxygenating and removing carbon dioxide. When the cardiopulmonary system fails, the body compensates for hypoxia or hypercapnia. Chemoreceptors stimulate the respiratory system to breathe more rapidly. The respiratory rate and heart rate increases and the blood vessels constrict. Respiratory distress. Its compensation is working. The patient has normal mental status, skin color, and oximetry readings. Respiratory failure is inadequate breathing. The compensation is not working. The metabolic needs of the body are not met. And respiratory failure is a precursor to respiratory arrest. Inadequate breathing occurs when a challenge is too great for the body's compensatory mechanisms. The rate of breathing, depth of breathing, or both fall outside of normal ranges. Recognition requires keen assessment skills and prompt action. Respiration, patient assessment. First, you want to determine if the patient is breathing. Second, determine whether the breathing is adequate. Signs of adequate in breathing include equal expansion of the chest is seen on inhalation. Air is heard entering and leaving the nose, the mouth, and the chest. Air is felt moving out of the nose or the mouth, and skin has typical coloration. Rate, rhythm, quality, and depth of breath are typical. Signs of inadequate breathing include mental status is altered, chest movements are absent, minimal, or uneven, pulse rate is slow in children especially, breathing movements are limited to the abdomen, no air is felt or heard at the nose or the mouth, breath sounds are diminished or absent, and wheezing, crowing, stridor, gurgling, or gasping are all heard during the breathing process. The rate of breathing is too rapid or too slow. Breathing is very shallow, very deep, or labored. Cyanosis is seen in the skin, the lips, the tongue, the ears, or the nails. Inspirations or expirations are prolonged. The patient is unable to speak. You will see retractions and nasal flaring in children. Oxygen saturation readings are low, under 95%, and body position indicates distress. Hypoxia is insufficient supply of oxygen to the body tissues. Common causes include a patient is trapped in a fire, a patient has emphysema, a patient has overdosed on a drug that depresses the respiratory system, or the patient has had a heart attack, a stroke, or an embolism. Signs include cyanosis and altered mental status. You want to address the cause and administer oxygen immediately. The patient care. You want to provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. Provide supplemental oxygen to the breathing patient. You need to intervene when you see signs of inadequate breathing. The patient's efforts are not meeting the demands. The condition will not progress without intervention, and it is better to be too aggressive than not aggressive enough. In this next section, we're going to talk about positive pressure ventilation. Positive pressure ventilation. Artificial ventilation is the use of positive pressure to force air or oxygen into the lungs. It is also called positive pressure ventilation. It is used when the patient has stopped breathing or has inadequate breathing. Positive pressure relies on the force that is exactly the opposite of the force the body usually uses. Use of positive pressure has negative side effects. Cardiac output and blood pressure drop because the heart's ability to refill its chambers is affected. Gastric distension occurs because air may be diverted into the stomach. Hyperventilation blows off too much carbon dioxide and leads to vasoconstriction. Next, we're going to talk about techniques of artificial ventilation. There are 3 methods that are common. The first one is a mouth-to-mask. It is preferably with high concentration supplemental oxygen at 15 liters per minute. A 2-rescuer bag valve mask, which is preferably with a high concentration of supplemental oxygen at 15 liters per minute, and a 1-rescuer bag valve mask with preferably high concentration supplemental oxygen at, guess what, 15 liters per minute. You do not want to ventilate a patient who is vomiting or who has vomitus in the airway. Positive pressure ventilation will actually force the vomit into the patient's lungs. So make sure that the patient is not actively vomiting. And if there is vomit, suction any vomit from the airway before you start ventilation. No matter what method you use to ventilate the patient, you must ensure that the patient is being ventilated adequately. To determine the signs of adequate ventilation, you should do the following. 1. Watch for the chest rise and fall with each ventilation. Ensure that the rate of ventilation is sufficient, approximately 10 to 12 per minute in adults and 12 to 20 per minute in pediatric patients. Inadequate artificial ventilation occurs when the chest does not rise and fall with ventilation. If air escapes around the seal of the face mask or the barrier device, and the rate of ventilation is too fast or too slow. Techniques for artificial ventilation should also ensure adequate protection for the rescuer from the patient's body fluids, including saliva, blood, and vomit. For this reason, mouth-to-mouth ventilation is not recommended. A number of compact barrier devices are available for personal use. So remember, the skill of assisting a patient's ventilations is difficult to master, and it requires careful watching for the chest rise and coordinating the delivery of the pocket mask or the BVM ventilation. When ventilating a patient who is breathing rapidly, you want to carefully assess the adequacy of the respiration. Explain the process to the patient. Place the mask over the patient's nose and the mouth. After sealing the mask on the patient's face, you want to squeeze the bag with the patient's inhalation. And adjust the rate over the next few breaths to ventilate fewer times, but with greater volume. When ventilating a patient who is breathing slowly, you want to carefully assess the adequacy of respiration. Explain the procedure to the patient. Place the mask over the patient's mouth and nose. After sealing the mask on the patient's face, you want to squeeze the bag with the patient's inhalation. Add ventilation in between the patient's own to increase the ratio to 12 per minute if it's not already there. Opening the airway. You want to clear, suction, and position the airway. You want to have the head elevated in a sniffing position, which is optimal. Flex the neck forward. Extend the head at the top of the neck. Suprasternal notch is even with the ear hole, and the face is parallel with the ceiling. Adjust the padding based on the patient's anatomy, and your younger patients are very challenging to actually position. You want to use the ramp position with obese patients. You want to raise the torso to a 45-degree angle. Plateau the head at the top of the ramp. Suprasternal notch is even with the ear hole, and the face is parallel with the ceiling. And ventilate the spine injury patients with the head in a neutral position if at all possible. Sealing the mask. A proper seal should allow the air to move into the lungs. The mask should extend from the bridge of the nose to the cleft of the chin. The mask should be wide enough to cover the entire mouth. 2 hands should be used to create a seal. The patient characteristics can make it hard to get a seal. Large, bushy beards should be wetted with water or water-soluble lubricant. Dentures should be left in place. Several things can optimize mask use. Raising the patient's head at a 30-degree angle, using an airway adjunct, and using a team to ventilate. With the mouth-to-mask ventilation, it is performed using a pocket face mask. Masks are made of soft, collapsible plastic. They have infection control features. They may have oxygen inlets. They are made with a clear plastic that allows for observation of the patient's mouth and lips, and they may have a strap to put around the patient's head. Here's an example of pocket face masks. With the mouth to mask for a patient without a spine injury. The EMT is at the top of the patient's head. You're going to position yourself directly above the patient's head, placing the patient in a head elevated sniffing position and insert that adjunct. You're going to apply the mask to the patient with the thumbs over the top of the mask, index fingers over the bottom of the mask, and the fingers under the jaw. Next, you're going to lift the jaw to the mask as you tilt the patient's head backwards and place the remaining under the jaw. While lifting the jaw, you're going to squeeze the mask with your thumbs to achieve a seal. And give breaths into a one-way valve and watch for the chest to rise. Here is a use of a pocket mask with a one-way valve. With mouth to mask for a patient without a spine injury, the EMT is going to be beside the patient's head. Position yourself beside the patient's head. Place that patient in a head elevated sniffing position and insert an adjunct. Apply the mask to the patient and place an index finger and thumb of the hand toward the top of the head along the top border of the mask. You're then going to place the thumb of the hand toward the feet on the lower margin of the mask and the fingers along the jaw. You're going to lift the jaw while performing a head tilt chin lift maneuver. Compress the mask against the face and give breaths into a one-way valve and watch for the chest to rise. With a mouth to mask for a patient with a spine injury, you're going to place yourself at the top of the patient's head. You're going to place the patient in a head elevated sniffing position and insert an adjunct. Apply the mask to the patient and the thumb side of the hands along the mask to hold it on the face. Next, you're going to lift the angle of the jaw, but do not tilt the head backwards. While lifting the jaw, squeeze the mask with your thumbs and fingers to seal it. Give breaths into a one-way valve and watch for the chest to rise. With the bag valve masks, they are used to ventilate non-breathing patients or to assist patients in respiratory failure. They provide an infection control barrier. They also come in adult, child, and infant sizes. They consist of a self-refilling shell and a non-jam valve that allows an oxygen inlet of 15 liters per minute. Here's an example of adult, child, and infant bag valve masks. With mechanical workings of the BVM, oxygen is attached and enters the reservoir. When squeezed, the air inlet closes and the oxygen is delivered to the patient. When released, the patient passively expires. As the patient exhales, oxygen enters the reservoir. To rescue or BVM ventilation with no trauma suspected. First, you're going to place the patient in the head elevated sniffing position and insert the airway adjunct. Select the correct BVM size. Then you're going to kneel at the patient's head. Position the thumbs along the side of the mask and press the mask downward. You're going to place the apex of the triangular mask over the bridge of the nose and lower the mask over the mouth and chin. Next, you're going to use the index, middle, and ring fingers to bring the jaw up to the mask and maintain head position. The second rescuer will connect and squeeze the bag until the chest begins to rise. The second rescuer releases the bag and lets the patient exhale passively. A two-rescuer BVM ventilation with spine injury suspected. First, you're going to place the patient in the head elevated sniffing position or neutral position and insert the airway adjunct. Next, you're going to select the correct BVM size. Then you're going to kneel at the patient's head, position the thumbs along the side of the mask, and press the mask downward. Use the index, middle, and ring fingers to bring the jaw up to the mask without tilting the head or the neck. The second rescuer will then squeeze the bag as for a non-spine injured patient. Here you will see that they are delivering a two-rescuer BVM ventilation while providing manual stabilization of the head and the neck. This is when trauma is suspected in the patient. One rescuer BVM ventilation. You're going to place the patient in the head elevated sniffing position and insert the adjunct. You're going to select the correct size mask and position on the face as for the two rescuer technique. You're going to form a C around the ventilation port with the thumb and index finger. Use the middle and little fingers to hold the jaw to the mask. Next, you're going to squeeze the bag with the other hand. The squeeze should cause the chest to rise. Next, you're going to release the pressure on the bag and let the patient exhale passively. If the chest does not rise and fall during BVM ventilation, you want to reposition the head. Check for escape of air around the mask and reposition your fingers and the mask. Next, you're going to check for the airway obstruction or obstruction in the BVM system and resuction if needed. If none of these work, then you want to use an alternative method of artificial ventilation. The BVM may be used during CPR. The bag is squeezed once every time a ventilation is to be delivered. In a one rescuer CPR, it is preferred to use a pocket mask with supplemental oxygen over a BVM. Artificial ventilation of a stoma breather. So first you're going to clear any mucus plugs or secretion from the stoma. You're going to leave the head and neck in a neutral position. Use a pediatric-sized mask to establish a seal around that stoma. Ventilate at the appropriate rate for the patient's age. And if unable to ventilate through the stoma, you're going to seal the stoma and attempt ventilation through the mouth and the nose. Improper ventilation rates can harm the patient. Too slow can cause hypoventilation and hypoxia. Too fast can cause hyperventilation and vasoconstriction. If possible, one rescuer should focus on ventilation while the other focuses on maintaining the airway and seal. Adults should be ventilated at 10 to 12 times per minute. Children should be ventilated at 12 to 20 times per minute. Improper ventilation volume can also harm the patient. Too much pressure can cause gastric distension. Too much volume can cause lung tissue trauma. Pressure should be slow and gentle. One hand or 2 to 3 fingers can be used to squeeze. Ventilation should be delivered over 1 second. Ventilate only until the chest begins to move. Do not ventilate to fully expansion. An automatic transport ventilator, also known as an ATV, provides positive pressure ventilation during respiratory arrest. It has settings for rate and volume. It is easily portable, and it may be beneficial when prolonged ventilation is necessary and there is only one rescuer available. The provider must ensure that the respiratory rate is appropriate for the patient's size and condition and ensures a proper mask seal. Here you will see an automatic transport ventilator. The coin is shown for a scale. In this section, we're going to talk about oxygen therapy. The importance of supplemental oxygen. Oxygen is an important and beneficial treatment. There are 3 major issues with supplemental oxygen. Oxygen is a drug, and it is possible to give too much or too little. Oxygen can also harm. It can actually cause damage to heart attack and stroke patients. Oxygen administration is based on evaluation. Saturation below 94%, hypoxia, and decompensation all suggest it is necessary. You always want to ventilate cardiac arrest patients. Oxygen equipment in the field must be safe, lightweight, portable, and dependable. Most systems contain cylinders, pressure regulators, and a delivery device. Other devices like BVM and pocket masks can be used to force oxygen into the patient's lungs. Cylinders are seamless steel or alloy canisters filled with oxygen under pressure. They come in various sizes identified by a letter. The D cylinder is 350 liters of oxygen. The E cylinder is 625 liters of oxygen. The M cylinder is 3,000 liters of oxygen. The G cylinder is 5,300 liters of oxygen. And the H cylinder is 6,900 liters of oxygen. They are all green or green and white. It is important to know which one your service will be using. The larger cylinders are used for fixed systems on the ambulances. Cylinder safety. Always use pressure gauges, regulators, and tubing intended for use with oxygen. Always use non-ferrous wrenches. Always ensure that the valve seal inserts and the gaskets are in good condition. And always use medical grade oxygen. Always open the valve fully and then close it half a turn to prevent someone from trying to force the valve. You always want to store reserve cylinders in a cool, ventilated room, properly secured in place. Always have oxygen cylinders hydrostatically tested every 5 years. Never drop a cylinder or let it fall against an object. It can become a missile. Never leave an oxygen cylinder standing upright without being secured. Again, it can become a missile. And never allow smoking around oxygen equipment in use. Cylinder safety. Never use oxygen equipment around an open flame. Never use grease, oil, or fat-based soaps on devices that will be attached to a cylinder. And never use adhesive tape on a cylinder. Never try to move an oxygen cylinder by dragging it or rolling it on its side or bottom. For safety, to prevent them from tipping over, oxygen cylinders must be in place in a horizontal position or if upright, must be securely supported. A pressure regulator must be connected to a cylinder to provide a safe working pressure of 30 to 70 psi. On cylinders E size or smaller, the regulator is secured using a yoke assembly. On cylinders larger than an E size, the regulator is secured with a threaded outlet. Before connecting a regulator to a cylinder, open the main valve slightly to clear the dirt and the dust. Flow meters allow control of the flow of the oxygen in liters per minute. There are two types of low pressure flow meters. Pressure compensated flow meters are used for larger cylinders in the ambulance. Constant flow selector valve can be used with any size cylinders. High pressure flow meters may be necessary for oxygen powered devices or respirators and ventilators. Here are examples of low pressure flow meters. Here is a high pressure flow meter. Humidifiers can be connected to the flow meter to moisten the dry oxygen from the cylinder. They are basically a non-breakable jar of water that the oxygen bubbles through. It's also known as a bubbler. They must be kept clean. Humidifiers, though, are typically not used by EMS because transports are short and they increase infection risks. Here's a humidifier in use on board of an ambulance. Hazards of oxygen therapy. Non-medical hazards are extremely rare and can be avoided by treating equipment properly. If the tank is punctured or a valve breaks off, the supply tank can become a missile. Oxygen can cause fire to burn more rapidly. And oxygen pressure and oil create a severe explosive reaction. Medical hazards can occur but take time to develop and are rarely seen by EMTs. Oxygen toxicity or air sac collapse occur when there is an overload of oxygen. Eye damage may occur when premature infants receive oxygen over a long period of time. Respiratory depression or respiratory arrest occur when hypoxic drive is depressed in the COPD patients. And underlying conditions can exacerbate as well as with myocardial infarction or even stroke. Administering oxygen. There are various delivery devices available. You want to work with myself or any other instructors with direction on how to understand how to use specific equipment. Furthermore, once you get to your respective department that you will be working for or whatever you decide to be doing, that you are actually asking them, how does this device specifically work? There are so many of them that we just cannot keep up, and it would be super expensive for all of us instructors to have one of each. Supplemental oxygen for patients with chest pain. Supplemental oxygen should be used when there is short of breath, hypoxia, or low oxygen saturation. For mild distress, you want to administer low concentration oxygen via the nasal cannula. For moderate to severe distress, you want to administer high concentration oxygen via the non-rebreather. And local protocols may offer additional guidance. A non-rebreather mask is the best way to deliver high concentrations of oxygen to breathing patients. It must be placed properly on the face to provide the necessary seal. You must inflate the reservoir bag before putting the mask on the patient's face. The reservoir must always contain enough oxygen so it does not deflate by more than 1/3. This is maintained at a flow of 15 liters per minute, and this provides concentrations from 80 to 90%. Exhaled air escapes through a flutter valve and does not return to the reservoir. A safety feature is an emergency port that enables the patient to receive atmospheric air if the oxygen fails. Non-rebreather mask should be used in patients with signs of hypoxia with shortness of breath, chest pain, and altered mental status. Here is a non-rebreather mask. Note the round discs, which are the flutter valves that allow the air exhaled by the patient to escape and is not rebreathed. And here is the non-rebreather mask that is not actually on a patient. A nasal cannula provides low concentration of oxygen at 24 to 44%. You will need to know these numbers, by the way. Oxygen is delivered by two prongs in the nostrils. Cannula is held in one place by placing tubing over the ears and using a slip loop under the chin. Oxygen delivered by the cannula should not exceed 4 to 6 liters per minute. The cannula is the best choice for a patient who refuses to wear an oxygen face mask. Here's an example of a nasal cannula. A partial non-rebreather mask is very similar to a non-rebreather mask. It does not have a one-way valve like the non-rebreather mask does. It allows the patient to rebreathe about 1/3 of the exhaled air. This is useful to preserve carbon dioxide levels to stimulate breathing. The partial non-rebreather mask delivers 40 to 60% oxygen at 9 to 10 liters per minute. Next is a Venturi mask. The Venturi mask delivers specific concentration of oxygen by mixing oxygen with inhaled air. Mask package contains different tips that provide different concentrations of oxygen, most commonly used on COPD patients. Here's what a Venturi mask looks like. Again, the Venturi mask, and it does look very similar to the mix of a non-rebreather and a nebulizer mask. Next is the tracheostomy mask that is placed over a stoma or the tracheostomy tube to provide supplemental oxygen. It is typically a small cup-like mask that fits over the tracheostomy. It is connected to 8 to 10 liters per minute of oxygen via the supply tubing. Here's an example of a tracheostomy mask. High concentration oxygen should be administered to children in respiratory distress, with inadequate respirations or possible shock. Infants and children may benefit from the blow-by technique. This is when you're holding the tubing or non-rebreather mask 2 inches from the face. Oxygen passes over the face and is inhaled. In this next section, we're going to talk about special considerations. First one is facial injuries. Bleeding may require frequent suctioning. An airway adjunct or endotracheal tube may be needed. Obstructions. Suction units are not adequate for removing solid objects. You need to use abdominal thrusts, chest thrusts, or even finger sweeps. Dental appliances. Dentures should be left in place during the airway procedures. Partial dentures may become dislodged during an emergency. You need to be prepared to remove a device if it endangers the patient's airway. Special considerations in infants and children. Here's some anatomic considerations. Their tongue takes up more space. The trachea is softer and more flexible, and the head is proportionately larger. The chest wall is softer and the diaphragm breathing is more important. Oxygen burn rate is twice the adult rate. Management considerations. Avoid excessive pressure and volume. Use properly sized face masks. Use pediatric-sized non-rebreather masks and nasal cannulas. And gastric distension may impair adequate ventilations. In this section, we're going to talk about assisting with advanced airway devices. Preparing the patient for intubation. Before a paramedic places a tube, you may be asked to give the patient extra oxygen. The paramedic will then position the patient's head in the head elevated sniffing position. The paramedic will remove the oral airway and pass the endotracheal tube into place. You may be asked to help with the burp maneuver. In the burp maneuver, you need to press your thumb and index finger on either side of the throat over the cricoid cartilage and gently direct the throat upward and toward the patient's right. Once the tube is in place, the paramedic assures proper placement via 2 methods. The tube is then anchored with a commercial restraint. You may be asked to monitor the lungs and epigastric sounds. Take care and do not disturb the tube once it has been placed and secured. Ventilating the intubated patient. There is very little movement can displace an endotracheal tube. Ventilate about 10 times per minute. Hold the tube against the patient's teeth with 2 fingers of one hand. Work the BVM with the other hand. If ventilating a breathing patient, time ventilations with respiratory effort as much as possible. Pay attention to resistance to ventilations and report any changes. If the patient is defibrillated, carefully remove the bag from the tube. Watch for any changes in the patient's mental status. During cardiac arrest, you may be asked to remove the BVM so medication can be injected. Assisting with trauma intubations. You want to provide manual in-line stabilization throughout the procedure. The paramedic will hold the manual stabilization while you apply the C-collar. You will then stabilize the head from the patient's side. The paramedic will lean back, use a laryngoscope, and tube the patient. After intubation, you will hold the tube against the teeth until placement is confirmed. The tube will then be anchored. You must hold manual stabilization in addition to a collar until the head is taped in place and on the backboard. All right, to recap everything that we discussed, we're going to do a quick chapter review. Respiratory failure is the result of inadequate breathing, breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilations. Oxygen can be delivered to the non-breathing patient as a supplement to the artificial ventilation. Oxygen can also be administered as therapy to the breathing patient whose breathing is adequate or who is cyanotic, cool, clammy, short of breath, suffering chest pain, suffering severe injuries, or displaying an alternative mental status. Remember to always use proper personal protective equipment when managing the airway. Assessment of breathing must be an ongoing process. Respiratory status can change over time. Inadequate breathing requires immediate action. Positive pressure ventilations are very different from normal breathing and can have negative side effects. Select the most appropriate method of positive pressure ventilations based on the needs of the individual. Always use appropriate safety measures when handling oxygen, and select the appropriate device to provide supplemental oxygen. Questions to consider. What are the signs of respiratory distress? What are the signs of respiratory failure? And for BVM ventilations, what are considered or recommendation variations in technique for 1 or 2 rescuers? How does the way positive pressure ventilation moves air differ from how the body normally moves air? And describe a patient problem that would benefit from the administration of oxygen and explain how to decide what oxygen delivery devices should be used. Critical thinking. On an arrival at an emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around her lips. Is the patient in respiratory failure? And if so, what signs and symptoms indicate this? Next, does the patient require artificial ventilations?